Kingstown Radio, the home of classic hits, and now I'm delighted to say that it's time to be joined by my special guest this evening. That's the man, shall I say, affectionately or professionally known as the Mad Doctor. It's Dr. André Carneiro. Hello, André.
Hello, good evening.
Now then, you're an anaesthetist, is that correct?
Yeah, you said it right as well.
Been practicing. Let's start at the beginning then. How did you first come to be a doctor? Did you from the start know you wanted to be an anaesthetist, or was it general doctoring? How did you sort of get into it?
Deciding to be a doctor was happened fairly early on. So after I've decided I really didn't want to be an astronaut, I thought medicine was the thing for me. So since I was about 12 or 13, I've decided I wanted a career in medicine. Becoming an anaesthetist was more of a spur-of-the-moment decision. After you complete your medical training, I was a bit at a loss to what specialty I would go for. So I've given anaesthetics a try for 2 weeks, and I was absolutely hooked. And I knew then that that's what I wanted to do for a career.
So how long had you been doing the sort of general initial training as a doctor before that happened? When did you reach that point?
Well, the proper medical training, certainly in Lisbon where I trained, it's a 6-year core medical training in university, followed by 2 years of heavily supervised medical practice. But I suppose you could say, because it's a very competitive entry into the medical training, I've been working towards it since I was about 15 years old.
Blimey.
Yes, quite competitive. The training in anaesthesia, of course, is another minimum of 7 years on top of all this. So actually it takes, on average, about 13 to 15 years to be a qualified consultant anaesthetist. So
what stage are you at the moment?
I'm not too far to go. Not too far to go. I'm a specialist registrar now. So hopefully, if all goes well, within the next 3 years, I'll be a fully qualified consultant.
So as it is at the moment then, do you actually go it alone when you're doing things, or do you still have to be with someone else? You know, are you watched over, or are you at a stage where you're actually doing things every day yourself?
It's a mix. We do have lists, and we do have our own duties that we do on our own, although there's someone who's nominally in charge and someone we can always get for advice. Okay. And then occasionally there are lists where you have physically a more experienced registrar or a consultant with you, and you have proper training during the working time.
And I don't know if it will be easy to do this or not, but can you go through, if you like, a sort of typical day in your life as an anaesthetist? Are all days the same? Are they all completely different?
Oh, at my stage, they're all very different. As anaesthesia is a very, very broad specialty, and you could say that you could be you can be an anaesthetist in theatre and mostly give anaesthetics. There is the critical care side of anaesthesia as well, in which case it'll be more based in intensive care. And then there is also the pain management side of anaesthesia, in which case you're mostly based in clinics. So at this stage, because I'm a registrar and I'm doing the rounds and having a bit of training in everything, I would say that every day things are different. Suddenly things change from month to month, which makes things quite exciting. Currently I'm doing pain. So I'm training in chronic pain, okay. And I'm very often based in clinics. Mm-hmm. Occasionally I go to theatre to have procedures done. Clinics are quite interesting. You do interact with patients a lot, starting normally standards 9 to 5 sort of job. When I'm in theatres, a day would start usually about 7:45 or 8 o'clock, and you'd go check the list, see what patients you have for the day, go and see the patients for about an hour or an hour and a half before surgery. Patients would have been seen or been pre-assessed, but you always go and introduce yourself and just check that everything is okay and that you have an anaesthetic planned for the individual patient and their individual surgery. So we tailor things as much as possible.
So there's various different types of ways to anaesthetise people. It's just not one set procedure.
Well, it does take, like I said, 15 years to be a consultant anaesthetist, so there is a lot to learn. Yes, a straightforward anaesthetic for a straightforward short procedure in a healthy patient is reasonably simple, even though you need to know what you're doing. Mm-hmm. But obviously the population, people undergoing surgery is changing quite dramatically. We're operating more in people who are more and more frail, particularly the elderly, and we operate on people who 10 or 15 years ago would have been declined surgery because they would not have been fit enough for it. So obviously, lots of things to consider. Surgery is more aggressive. Patients have multiple problems with them, and we need to tailor the anaesthetic and each pharmacology or each anaesthetic agent to the patient's condition and to all the drugs they're having, how they interact with our anaesthetics, how to interact with each other, what we do afterwards. So it can be quite challenging.
So there must be a lot of interaction with your other colleagues as well then. For example, you just mentioned checking their other medication to make things compatible. How easy is that to sort of cooperate with your colleagues, when you're all from separate departments? How does that work?
I would suspect that the bulk of our interaction is actually with the surgical team. Okay. And obviously we are physically in the same place. As the surgeons are operating, we're anaesthetising, so that's not too bad. With regards to the patient's general condition, many times we have to refer quite heavily to the patient's notes and things that come with the patients from their general practitioners. And that is a wealth of information there. Of course, those are not always available, particularly in emergency cases when people present for surgery at a short notice for major problems. I must say that's my favourite. Certainly the major trauma patient, the polytrauma patient, it presents a very interesting set of challenges, and as I said, not knowing the full history and the full patient's background makes things a little bit more interesting.
Do you remember then your first incident where you were, sort of at the stage where you were qualified enough to be doing it yourself? Does one incident sort of stick in your mind as being the first, most nerve-wracking? I realise you can't mention names or anything like that, but any incidents that stick in the mind?
Yes, there is actually. When I started in 2001 in the UK, end of 2001, the anaesthetist normally is part of the cardiac arrest team, so if someone has a cardiorespiratory arrest, we get called as an emergency to that patient. And this was probably about my fourth day on the job. And arguably I wasn't quite sure exactly what it is that I was supposed to be doing at that stage, and we got a cardiac arrest call. Right. And I remember vividly me running like mad to this patient who had collapsed. And everybody looked at me and said, "Oh, thank goodness the anaesthetist is here." And I felt absolutely out of the water. I had no idea what I was doing.
So everyone was waiting for you to arrive?
That's true. Fortunately, my senior registrar came soon after, and she quite expertly took over. But it was very nerve-wracking. It's very interesting.
And any unusual sort of cases that you've come across?
I wouldn't say unusual, but I have had the pleasure of transporting a patient by helicopter, which was in itself an unusual experience, rather exciting, but unusual, I suppose.
How did that come about? Were you with the helicopter crew for the day, or something just happened and the helicopter arrived, or?
I was working at a district general hospital, and the patient had sustained, he had a head-on collision with a wall in his car, unrestrained, no seatbelt. Right. He had quite extensive damage to his liver, and we had to perform the initial stabilisation damage control surgery, but he then needed to go to a specialist liver unit for further care. Now this was... the hospital where he was going was a fair way down the M6 in rush hour, and we felt that really it was going to take quite a long time, so I ended up escorting the patient by helicopter to the receiving hospital.
Do you mind flying?
I love flying.
Yes, I kind of knew that, but maybe you could explain to the listeners?
I'm quite partial to flying. I have a private pilot's license,